Hi, my name is Amy Webster, and I'm here today to talk to you about leadership models in healthcare. Leadership models matter. Healthcare is complex and it's rapidly changing. And how healthcare organizations deliver care matters. With advances in technology, innovative tests, and evolving patient demographic, leaders have to be able to guide their organizations through those changes to maintain high quality care. So we're going to look at the PARP and dynamic culture leadership. We're going to compare them and decide which model fits healthcare best. Looking at the PARP model, PARP stands for Purpose, Assemble or Charter, Align, Resource, and Perform. It was developed by Stevens, Ludlow, and Scott. PARP emerged from the recognition that interprofessional teams are central to modern healthcare leadership. It provides a simple yet powerful structure for guiding diverse teams through shared success. PARP offers teams a roadmap, and each phase is designed to build on the last. From problem, defining the problem, to analyzing the problem, offering alternatives, recommendations, and the plan. That step-by-step flow helps healthcare teams stay focused, reduces confusion, and delivers consistent results. If you were to see this model in action in Medicaid managed care organizations, PARP would help align care managers, provider relations staff, compliance officers, and member service representatives around a shared care coordination strategy for high-risk members. For example, high-risk members may need to get care for their diabetes. So this model would help define the problem. Why are members missing their diabetic care? It would analyze that. Then they would look for alternatives or solutions, provide recommendations, and then plan. PARP builds consistency and morale through disciplined teamwork. Dynamic Culture Leadership Model, or DCL, is really the science and the art of leadership management. It looks at leadership that adapts, empowers, and shapes organizational culture. There are three levels: personal levels, the team level, and the organization. And adaptability and innovation is really at the center of this model. When you think of a real life example of DCL in action, it takes me back to during COVID-19's pandemic. Many healthcare leaders had to rapidly adapt their organizations to handle an influx of patients. If you remember during those times, there were patients waiting in the hallways for hospitals. Hospitals were running out of beds. They had to implement new safety protocols. You may have had loved ones in skilled nursing facilities who were no longer allowed contact with the outside world. And because people still needed other care that may have been too risky for them to go to the hospital, and remember, hospitals were overcrowded now, it helped guide healthcare organizations to transition to telehealth services. This required quick decision making, flexibility, and the ability to guide their teams through unprecedented challenges. So the DCL model builds resilience and fosters a culture that thrives in uncertainty. Looking at the two models side by side, there are things that they share. Both the PARP and the DCL recognize that healthcare's success depends on collaboration. In both models, organizations collaborate with one another, whether it be in the managed care organization, the care management team and the call center, the provider relations team, the utilization management teams. All of those work together. And that teamwork, through PARP is through defined phases, while the DCL builds on collaboration, shaping culture, and empowering teams. There's structure versus flexibility. The PARP model offers discipline and a step-by-step roadmap. It looks at the purpose, assemble, align, resource, perform. DCL, on the other hand, emphasizes adaptability and continuous improvement, which makes it more fluid in dynamic environments. The leadership roles. In PARP, leaders provide clarity of purpose and consistency of action, while in DCL, leaders act as culture shapers. They model the values they want to see. They respond to crises and empower innovation. The strengths of each model are different. PARP's strengths lie in clarity and the ability to align diverse professionals around shared goals. And DCL's strength is its resilience and adaptability to thrive in uncertainty. PARP can feel rigid when rapid change is required because it's very structured, while the DCL requires strong leadership, buy-in, and cultural commitment. Getting that buy-in can be challenging, and that can make that model challenging to sustain long-term. This comparison shows while PARP is excellent for structured teamwork, DCL better addresses the fast-changing, complex realities of healthcare organizations. So, which model is best for healthcare? Healthcare is always moving. In managed care and across healthcare, nothing stays the same. You may do something one way today, and tomorrow that can change. Regulations change, technology evolves, and members' needs change. A leadership model has to keep pace with that reality. And DCL is built for adaptability. While PARP gives us structure, DCL gives us flexibility. It's designed for leaders who need to pivot quickly, innovate, and keep teams aligned when the environment changes overnight. Culture is often at the core of a healthcare organization, and DCL puts culture at that center. Leaders model values, they build trust, and create space for collaboration and innovation. And DCL empowers the frontline staff. For example, in Medicaid managed care, the real impact often happens at the front line with the member services team, the care managers, provider relations. And DCL empowers those teams to bring forward solutions that improve those outcomes and the member experience. In Medicaid managed care, call centers are often the first to hear about a member's real-life challenges. Under the DCL model, leaders empower associates to act on those insights instead of just logging them. In the call center agents are often the first to notice a pattern or an issue. Most recently, if you think about the government shutdown and when food benefits for SNAP recipients were halted, members may have called into the call centers to ask, or mention that they needed help with food. They didn't know what to do. So in that approach, in the PARP style, that issue might have simply been documented and passed along. With the DCL model, leaders encourage call center staff to elevate those trends, to collaborate with the care management teams, and connect members with community partners like food banks and local pantries. That empowerment transformed the frontline observations into really system-wide actions, helping address food insecurities as a social determinant of health. By giving the call center teams a voice in problem solving, DCL turns everyday member conversations into opportunities to improve health equity and quality outcomes. Sustainability matters. PARP helps with consistency, but DCL builds resilience by shaping culture and embedding adaptability. DCL positions organizations to sustain performance long term and not just in the moment. Both models have value, but healthcare's complexity demands adaptability and cultural shaping. That is why DCL is the stronger fit for healthcare organizations. PARP equals structured teamwork, and DCL equals adaptive leadership. DCL is a better fit for the health organizations because it is adaptable, flexible, and looks at the complete picture. Healthcare can consistently change, and healthcare organizations need leaders who can adapt and deliver better outcomes for our members. Thank you for allowing me to speak with you today. If you have any questions, please let me know. Please feel free to visit the references on the reference slide. Thank you. Have a great day.